Welcome everyone, and thank you so much for joining us today. I am thrilled to be here with two maternal experts in healthcare. I'm here with Melissa Lawler, who is an innovative and passionate leader in the fire and EMS community. She serves as the Deputy Coordinator for First Responder Health and Wellness in Dutchess County. She has a remarkable 30-year tenure as a volunteer in the fire and EMS realm, and she also serves as a Pleasant Valley Fire Commissioner. She seamlessly integrates her expertise in fire and EMS, midwifery, and family practice medicine. She's a trailblazer in EMS continuing education. She develops cutting-edge CME sessions with evidence-based practices, and her work spans OB, GYN, newborn, pediatrics, firefighter, EMS health. What don't you do, Melissa? And she addresses unique health challenges that are faced by women in fire. I'm also here with Laerdal's own Dr. Elizabeth Travis. She is a paramedic, educator, and healthcare leader who is advancing maternal care in pre-hospital settings. Her doctoral research focused on improving outcomes in maternal care deserts through midwife-style paramedic training. Elizabeth is a former lieutenant paramedic and EMS educator. She's trained clinicians in high-performance CPR, maternal postnatal care, and stress management. Her work has been featured in the GEMS report and presented at EMS conferences. She serves on EMS nonprofit boards and continues to present and speak nationally on maternal health and emergency care. She's also very excited to be welcoming her second child into the world in a little over a month. What perfect timing for us today. I'd love to hear just a little bit of intro and talk about what inspired you both to focus on maternal care and EMS collaboration.
I'll go first. So actually, through my career as a medic, when I got pregnant with my first, I went and I saw a midwife. And I noticed going through that, I always knew there were gaps in training for medics in maternal care. It's pretty obvious when you're going through that training. It's not contextualized for us. And that always felt like a misstep to me. And then when I was starting with my first, with the midwife, I realized, why aren't we doing this? You know, we can meet that gap. And at the time, there was a gap, but it's not as big as it is now. I said, we can meet that gap. So I pivoted a little bit. I focused my research on that. And that's kind of where it all was a springboard for me, was with my first and really getting to know the midwives and just their role and community birth workers, how we need to work much closer together and how EMS really could step up to that. Even without any protocol change, without any big shifts to what they're doing, just with better training and contextualization of what we're doing. So that's kind of what springboarded me into that world, and I've stayed there and I've really enjoyed it, and it's something that it's a needed focus. So
that's wonderful. How about you, Melissa?
So my story, like you said when you did the intro, I have a little over 30 years in fire and EMS. And so I started out in that world as a very young 19-year-old. Also had my first child in the fire service and EMS service, and which is actually plays a role in a lot of the work I do now in reproductive health in the fire and EMS world. And when I had my baby, I also used a midwife, and I learned through the process that with the midwifery care I was getting, it wasn't matching up to what we had been taught in EMS. And I said, oh, this is interesting. And I was, young at the time. I was 21 with my first child. And moving forward, I went in to get my RN, and what we were being taught as an RN, again, didn't match up to what we were being taught in EMS. Mm-hmm. So flash forward, when I became a midwife, I knew this was something that I really wanted to tackle because the gaps of education are there. Mm-hmm. And when you learn midwifery, you are in all three different elements. You're in community birth, which is home birth, it's birth center, it's out of hospital, and then also in the hospital realm. And I've practiced in all three as a midwife. And I said, I can make sure that I can make a difference. Mm-hmm. We can teach this, it's education. Yes, there's some protocol changes that need to be made, but this is really simulation and education, mm-hmm. and delivering it with style and pizzazz and understanding and teaching it from our point of view because we're actually really similar.
Yes.
So that was my
And you are
springboard.
making a difference.
Thank you.
Can we talk a little bit about why this topic is so timely for our EMS audience that's here with us today?
Yes, I'm gonna defer this to our doctor because this is what she studied.
Yeah, so we've seen it. We see it a lot in the news. I know Melissa and I, we have kind of a beat on that perpetually, but you'll see it more and more roadside births, more out of hospital births. Some of them very wonderful stories, some of them on the sadder side. And what's happening is there's a shift within healthcare right now where we're losing labor and delivery departments. We are losing the workforce of midwives, actually. There was a big push against midwives at the beginning of about the 1900s, and they've come back, which is wonderful. We love having them, but there's still that mentality, right? So what's happened is we've created a big provider gap, and mothers are not comfortable with the healthcare system as much as they were in terms of taking care of their children, or they just can't get there. And I know we'll talk a little bit about the deserts, but there's just a large gap in availability of actual care. And who is called to meet that gap if you don't have a midwife there? Maybe you want a midwife and you have a doula, but they can't manage everything, right, medically. They call us, they call the medics, they call the EMTs, and you're out there and you're about to get a lot more calls because we're looking at bigger gaps in actual availability of care. And you're that middle ground, whether you're a volunteer, you're a career medic, you're now the care. So historically, we haven't trained as much on this, right? We do a bit of training normally in a hospital, but we haven't trained our medics to actually go out and understand the whole spectrum of care and the whole system and how it works together efficiently to really help tackle morbidity and mortality as it is in the United States for our moms. So at this time, yes, people are starting to see it's kind of starting to roll in that direction of we really need to start stepping up and doing something, or we're going to have a much bigger crisis on our hands than we already have in the United States.
So that's a great segue. Is there anything else that we want to add about talking about where we are today with the current maternal care in the United States? I know you mentioned a little bit about maternal care deserts, and you've already kind of jumped into one of the questions I had teed up, which is wonderful. But is there anything else either of you would like to add to that?
Ooh, yeah, 5 years. I think probably 5 years down the line, what we're going to be looking at is a bolstering of paramedics and EMTs in that kind of birth space. And we're really going to see more care and attention to that because, as I mentioned earlier, the problem with the deserts is we as a nation have tried to put out some solutions, right? We're going to bolster midwives. Well, we can't out-recruit a crisis, and we already have the medics there who could step up and take that place. So we're really going to start seeing that evolution of care in the next 5 years, in my mind, I think. And I think Melissa might agree with me as well. Like she said, we're a stopgap. So myself as a medic, I know in the previous 5 years that my knowledge and training has grown exponentially because people have come to me and asked, oh, I had a home birth. This is what happened. What do I do? Or I know somebody who's going to have a home birth. What should they do? What should they be asking the medics? Or what should they be looking for in a midwife? So we're going to see that. I think EMS is going to step in to fill that gap, like Melissa said. And instead of having to out-recruit a crisis or look at trying to re-bolster the hospital system with the labor and delivery wards, because that's going to take a lot more time, it's going to be the medics. We're going to have to integrate better into that whole continuum of care. So in the next 5 years, that's what I anticipate we're going to see. We're going to see a lot more working with midwives and birth centers. We're going to see a lot more understanding of what a doula does, what a midwife does, how, moms to the hospital. Some moms aren't going to want to go. So how do you manage that? How do you manage a home birth of a mom who had a home birth because she wants to stay at her home? She doesn't want to go to the hospital. So we're going to have to meet all those. And like Melissa said, I think trauma is a really important topic to dive into a little bit here, and not just trauma for an EMS crew who might not be ready to step up in those 5 years, but of the mom. It has to be understood that her birth experience in her head, just a very specific thought process for each individual mom. And something as simple as maybe giving birth in the back of the car, which is not what she wanted, but she didn't get there, that's a trauma experience for her. So you have to be able to understand and communicate as a provider really well in those situations to help mitigate that. And that affects health down the line for mom and baby as well. It's something we don't think about as much. We often think about the very physical, but there's going to be that shift to understanding the physical and mental aspects of maternal care as we look at it moving forward.
Right. I'd like to bounce off of what you said, because I think what you brought up was a really crucial point. This is her birth story. And it's not only just her birth story, but it's also the birth story of her child. It's the birth story of the partner. And what is the role that we play and the energy that we bring into that space? Because this story might not be what she envisioned in her head. And it certainly is probably not what you thought was going on when you got dispatched. So there's a couple different plays here, and how we use our language to inform the care on both sides, right? Like that's super important, and it's a piece that gets missed. So it's really easy, I don't want to say easy, but it's teachable. That's a skill set that's teachable. When I look at 5 years down the road, my goal is the collaboration all the way through. What this looks like from a midwifery birth that's a community birth, and she has things that are starting to go a little bit more. There's some red flags that we need more. We're really trained really well to understand when things are not, like we have to act much quicker, like because we don't have the access to a hospital or to an OR right down the hall. So we are much quicker to act. We have that knowledge there. We're really well trained to do that. So if you're calling EMS in, there's definitely an aspect of that we need, that we'll be able to talk about that. And then also, if we have, because of these maternity care deserts, which are growing enormously in the United States, and that's an area of defining what a maternity care desert is, which is you have no services. There's no access to care. There's no obstetric provider in your county. So how far is she driving? How far is her partner driving? If she's even able to get transportation. So when I talked about the social determinants of health, what does that look like for her? Does she have transportation? Is she in an Uber? Is she with a family member or a friend, right? And is she driving 30 miles, 60 miles, 90 miles to get even to the facility that she's choosing to birth at? So those are things that we need to look at, because it's two different models. You have one where you're coming in as EMS with a higher level of provider of care, and then you have one where you are the highest level of provider of care on the side of a road, in a parking lot, in a gas station. So these are two that we need to learn how to collaborate really well together. Like I said, we have a lot in common. Then when I look at where the delays of care are, because we know delays of care is where the maternal, not just for women, but for all across, when you have patient delays of care, we have morbidity and mortality that play in that. So where are our delays of care? And we know that they're in the transfer from community birth to EMS, from EMS to the hospital. How can we do better across all three of those realms? And that's my goal in the next 5 years, to really get those synced well together.
Such important reminders. Let's talk a little bit about EMS education and current practices. I'd love to hear a little bit more about where EMS education currently stands regarding obstetric care. I know you're both very passionate about this and areas of opportunity, but
Yeah.
how would you share that with our audience?
I love that you asked this question, so thank you for bringing it up. This is a passion point for me. It's really a huge passion point for me. Because I think what's going on out there, I know what's going on out there, because the feedback I'm getting from students that I currently teach on this, and I present nationally about this topic, there's confusion.
Mm-hmm.
There's so much misinformation out there, and it's not evidence-based practice. It's not current with the times, with how we're practicing. And so for me, being able to, I love teaching. I absolutely love teaching. I love going out there. I love watching the light bulb moments when you hit it with them and their face lights up and they're like, yes, I got it. And so I think if we can move forward with EMS education in birth, not with a PowerPoint, but they need hands-on. They need simulation. They need to hear and experience what a mother is saying and the commotion that goes on or the silence that goes on, because some are silent birthers. We have babies that come into the world a little bit on the more quiet side too. And, you know, some that enter the world like, hey, here I am. And they are like, you know, very boisterous about when they're coming into the world. So I think that when we can provide that level of evidence-based practice, using hands-on simulation, having all 5 senses involved, we gain a much more competent, confident provider. And they're not scared coming into a birth space for a high acuity, low frequency event.
And as you mentioned, every story and scenario is unique.
Right.
Yeah, and I think to bounce off that, because I know, right, I went through all levels that I could have in Virginia. I'm a Virginia medic, but in my EMS training, in my advanced EMT training, and then in my medic training, what we're doing for education in EMS is a non-contextualized version of what we're doing in the field, right? I went into a hospital and watched C-sections, which I'm sure is probably a large portion of what everyone is probably sitting there going, yeah, that was my experience too. And you go out into the field and you do a field birth. It is not controlled. It's an uncontrolled environment. And I think that sets us up to get very amped before we walk into that house, you know, and it needs to be a calm environment. You need to be calm and confident. Like Melissa said, we have to set providers up to be competent and confident in what they're doing. And our current training is more, oh, well, you're going to show up, she's going to have a baby, you're going to do these couple things, it'll be fine, take her to the hospital. And it's a disservice, I think, to EMS to train us that way, because we're ready to do more. We've seen it with cardiac arrests. We've seen it with traumas. We are able and ready to do more. We have to be trained to that. And I actually know from my own research that that's part of the largest missing link is all these medics were telling me, we'd love to do it, but we're terrified going in because we haven't been trained to do it. Everything that we've been trained on is just kind of a prompt trainer or none of that. We just went into the hospital, but we can do it. And then from the mom side, because I talked to both, they were like, we want them to be trained. We know they're not trained. So it is a missing piece to what we're doing. And it's so, in my mind, like Melissa said, it's so easily remedied, really, when you think about it. And it doesn't have to be big simulation, right? It just has to be contextualized, and it has to be more than you're going to catch a baby and clamp a cord, which is where we a little bit are, I think, nationally. Now, some agencies, you're going to get a lot better training, right? There's always a variance. Some people are very ready to go. They are there. They are stepping up to that challenge. But for the majority of what we see, especially when we're looking at the care deserts, which are mostly rural, they're still on more of an outdated protocol, on more of an outdated training, just trying to keep up with what they need to keep up with.
So I heard you mention the EMS provider's fear that is just kind of innate in many providers. What are some of the ways that you think that those can be overcome, and how can training help them with those fears?
I think it's drills, it's practice. It's like CPR. You know, when you drill it down and you're practicing it, you become rote memory in a way. You're just doing the job, right? You're doing it. And that, I think, again, is easily remedied. It's education. It's getting out there and doing it. I do want to circle back to one thing that we had talked about, and is EMS is trained in hospital birth, and community birth is a very different story.
That's right.
And so for being able to put an EMS provider in that environment of a community birth is super important, because the hospital birth is more controlled. And you have all the resources available to you. And we know when we're in an ambulance and we're out in the field, it's like MacGyver.
Yeah.
Right? We have to we have to have right there what's at our resources and be able to think quick on our feet and act so fast. And so to me, when you are able to bring the EMS out into that simulated type environment, we're going to, again, make a more confident provider. And that when you have confidence and you're feeling comfortable in your skill set, you're going to have less fear. I mean, the fear is always going to be there, but you'll have less. And I also know that when I teach EMS for childbirth, for birth and neonatal resuscitation, we talk a lot about grounding yourself in the moment.
Such a helpful reminder. Liz, anything you'd like to add?
I think that about covers it. You know, we talk about contextualization, big thing, and getting our providers competent. And a large part of that is just when you're doing your training, stop training like you were taught, which is the hospital setting, right? Start training in weird spaces. Start training in the bathroom. Start training out in the cars. Things like that. I mean, small shifts, right? So, yeah, that's the nail on the head right there is we're not in a hospital. You know, a community birth is wildly different. And it has to be understood. We go in and we might be nervous. There's always going to be some of that nerves. But maybe that mom isn't. You know, we talk about community birth like it's always going to be this big unplanned event. A lot of moms are shifting that way. You know, it is not, unless you have a higher risk pregnancy. Normally it's a safe and very nice way to have a child, to bring a child in this world. You're in a space where you're comfortable, where you know what's going on, your family's there, sort of deal. So it has to be a mental shift as much as it has to be a actual training shift in medics' minds to understand, okay, was this planned for them? Am I walking into a mom who's probably calmer than I am about this situation? Or is this the side of the road? Is this a gas station? You know, where does my mental space need to be for myself and for the mom in this kind of situation? So we have to add that into our training, which in my mind it's a bit harder, right, to add in that mental part, but it's just as important. And that's where you're going to get full confidence, is where you are able to assess, and we're great at assessing. I think EMS is some of the best assessors I've ever seen because we see it in all sorts of situations. You need to be able to train that same assessment instead of training everything is an emergency, right? That's what we train now. If you're having a birth out of the hospital, it's immediately an emergency, unless it's a very set, the birth is the exact way they showed me when I went through it that one day in class. And that's just not the case. You know, we have the tools at our disposal to birth a lot of different positions, a lot of different baby positions. You can do a breech birth, you know this, in the field. And right now in medicine, a lot of women are told, nope, your baby's breech, you're having a C-section. We don't have that luxury in EMS. If the baby's breeching, the baby's coming, you need to learn how to manage that effectively. So I think to Melissa's point, it's just drilling it. That low dose, high frequency, yeah, it's not going to happen a ton, but that's the same with cardiac arrests. I mean, we think about them as providers and we think we have so many of them, and that's because the statistics float around our agency and we did this many arrests this week or this month, but how many of the providers were on that call? You know, how many arrests are you actually going to yourself in a year and being a main participant? So I think it needs to be sort of that same mentality of it's a high acuity, low happening event, but that means it's even more important to train it.
Right. Now, for those agencies that are wondering, where do I start? Are there any small changes that you think, either in training or protocols, that could make a big difference? Just some ideas.
Yes, so I'll let you go first, and then I'll add on, because I know we probably both have some thoughts.
Small changes. Wow, okay. I think, first of all, Liz and I always go immediately to skin to skin.
Yes.
So
I felt it coming.
Yeah, skin to skin. Baby belongs on mom. So when we go to these births, Christine, you know, it's not just the mom. We now have a second patient. We have two. And sometimes we might have three if the partner goes down from a faint, right? So we want to acknowledge the fact that we've got a baby that's been born. It's her baby. Put this baby skin to skin. That's where they belong. We don't have an incubator. We don't have one of those little, doohickeys in the hospital that you put a baby under to keep warm, right? We don't have that, but we do have mom. And mom regulates baby. and baby regulates mom. So when they're together and they're skin to skin, and I'm not talking a towel in between, I'm not talking about a shirt, I'm not talking about any of that, it's skin on skin, drying the baby while the baby's skin on skin, keeping them together. Mom's heat regulates the baby. We do know the research shows that EMS brings in hypothermic babies. So this is one way to keep your baby at the normal temp. Mom's heart rate regulates baby's heart rate. Mom's breathing regulates baby's breathing. So we want to keep them together. Put the towels and the warm blankets over top them both. Keep them dry. Delayed cord clamping. That's another thing that we can do. So these are small changes. They're evidence-based change. These are following the current best practice guidelines. From who? From ACOG, from ACNM. We can do this together. Put mom and baby together. And delayed cord clamping is absolutely critical for baby because 1/3 of the baby's blood is still in the placenta. We want the baby to get all their blood. We know it's beneficial for them. The research shows that. So waiting for that cord to stop pulsating, and that's a super easy feel for EMS. You just are gonna feel the baby's cord. You can feel if they're still pulsing or not. And if they're not pulsating and it's limp like a piece of spaghetti, it's okay now then to go ahead and clamp and cut the baby's cord. So those to me are two very small but very beneficial physiologic changes that we can make in EMS.
We both do go to skin immediately. That's why I knew she's going to say it. I know she's going to say it. No, but I agree with that 100%. Wait for non-pulsating for the umbilical cord, or I'm a big advocate of the wait for white, which is the whole, you'll see it, the whole umbilical cord will turn white and then you're free to clamp. But we are taught, take the baby. And unfortunately, we're taught, take the baby away, which is such a misstep. I mean, it's just such a small shift. And you'd asked about protocols. That's a bigger shift. When you talk about doing protocol changes in EMS, those normally have to go through a whole process, through a review, through something. It's not just, ooh, let me strike this out and add this in. But within what we're already doing, there is no reason you cannot immediately put that baby on mom. And if mom isn't available for whatever reason, put the baby on dad. And it's those shifts, right? The mental shifts of how do I get this baby regulated? And it makes it easier for us. Why would you not want to make it easier for you? Like Melissa said, we've seen the research. We know respirations, nervous system functions, warmth, all of that. Skin to skin is going to help regulate any of that. So you're making your job harder by taking that baby away. I think another one that's coming up, not necessarily in the United States, but I would really like to see it be more of a push in America, is something called intact cord resuscitation. Where you are waiting for white, but maybe baby came out and they're not breathing well in that first 30 seconds. It can take a couple minutes for all of that blood to transfer, and you are resuscitating that infant still attached to the cord. Not necessarily skin to skin with mom, because you might need some better access to their chest if you get to the point where you need to do compressions, or their face where you need to do more oxygen, but you're not harming anything by waiting. And I think that's a big shift in mentality, is it's okay to take the pause in these situations and just to wait a minute. So those are the three big things that I always talk about. And there are some little one-offs, like understanding water births, when to take a mom in and out of the water, because you're going to show up, somebody's going to have gotten in the tub because it feels nice. The other thing that I think that EMS can really train on is variable birth positions. And this is something that I hound when I teach. We're taught on your back, supine position, mom's gonna have a baby like that. It is known to be one of the most painful ways to have an infant. Your hips aren't set up correctly, it's harder to push, it just makes everything harder. So we need to teach EMS, all fours is fine, standing up is fine. There are so many ways you can have a baby that are a lot more advantageous to the mom. And when you do that, again, you're helping the mom. It's going to help decrease tears. It's going to make it an easier labor. You're helping yourself, because more tears mean a harder understanding of, is it a true hemorrhage or is this coming from a tear? maybe the mom doesn't want to go to the hospital, and you don't want to have that fight of, hey, you have a 3rd-degree tear, you have to go get stitches sort of deal. That adds another layer on. Then you got dad there. Maybe we don't want him to faint. So just keeping those things in mind, skin to skin, intact cord resuscitation, delayed cord clamping, and then understanding actual birth positions and how the hips can open much better to make it a much easier setup for the mom and for you, and just getting comfortable to catching the baby in those different birth positions, right? Because we're taught supine. It's super easy to catch a baby that way. Not as easy to catch a baby if mom is standing up or she's on all fours. It's just a little bit different maneuvering. And sometimes, you'll have stuff like a cord over the neck. How are you going to slip that off in this position versus that? But I think those are some of the 4 really easy things that we can immediately address without having to do large protocol shifts.
I think the working with gravity is so important.
So great.
So important, right? I would love to, this is another thing. The tin foil that comes out and babies get wrapped in, they're not tacos or burritos. So like, if we could put skin to skin again with mom, best regulation for heat, right? So that's something else I would like to see. So
I do love the little foil burritos. I've always thought it was funny. We have towels and we have sheets in the truck. It's okay to take those in, use those, especially if you're doing like, it's a community birth and they're at home, they're maybe not in a car or anything like that. They got blankets, I promise you. There are baby blankets in that house.
And Melissa, I know you've done a lot of training in your area. Would you mind talking a little bit about some of the successful programs and simulation training that have helped improve outcomes?
Okay. So I do have this training that I've put together that we're teaching when I go. In fact, I just taught at EMS World last week on this maternal infant essentials with a co-presenter. So this is something that we've been rolling out alongside neonatal resuscitation from a community birth aspect. And then locally, I take what I've put together, which is like a 2.5-hour birth, normal physiologic birth. I also have another 1.5, 2-hour breech birth training that's been put together for EMS as well. And then I would like to say that the more education, we know that this is what the research shows, the more education you have in EMS, the better your outcomes are going to be. So I would love to say I had all this documentation that all this training I've been doing is making a huge difference, but I don't have, that's a whole research topic, right? And we do know that. So I know that the neonatal resuscitation for sure, when you're teaching it from, again, a community birth aspect, because it's not in the hospital, the resources that you have are wildly different in a community resource than in a hospital. Mainly manpower for sure, the people that are around you, and it's a team. Where when you're out in the field, it could be 2 or 3 people. I think also the program Step Up Together is doing a lot of work around the drill aspect and the training aspect, and including EMS. When I talked about the delay of care, from that model, involving them in with that, coming from the birth center model into the hospital, and they're the middle piece. So that's been something that's been a really advantageous addition into Step Up Together. That's a new program.
Yeah, brand new. I agree with that, and I think to Melissa's point, you'd love to say that I know somewhere that's doing something really great and it's going to spread, but the thing is, and we say it all the time, but here it comes again, if you've seen one agency, you've seen the one agency. Yeah, right, you've seen the one. And so I've walked into EMS agencies where there are providers there that are, they're in deserts, they've birthed 5 kids already that year, it's only July sort of deal, and they're super comfortable with it, and they've gone out and they've learned on their own. But we can't put the impetus on them all to go learn on their own, right? So I think there are lots of little bits and pieces, things like what Melissa's doing, like what I'm doing, where we go out and we're trying to push it. We're trying to say, hey, knock on the brain, this is an important thing you're going to need to start understanding, not just for you, but if you're really caring about your patients, it's for your patients as well. But there is no complete program. It's the training that you get as a provider, that initial training, and then it's the video that you maybe watch every 2 years, which it's better than nothing, right? We don't want to say it's necessarily horrible to have to go watch these things, but they're old, they're outdated. The evidence has moved so much quicker in that because it's had to, and we're just not there. So really, until you put together something in your agency, it's going to be hard to go out and say, oh, I know this program. This is contextualized to EMS. This is going to work great for me. Now, there are some things you can get to help. Simulators, or even better, prompt simulated trainers where you can put them on people and get them into weird positions. But again, you have to create that. And we're asking a lot of EMS to ask them to create those things. They're not necessarily educators. Like, I think everybody in EMS loves to educate. We like to teach our providers, but it's different when you're coming in and saying, hey, now you need to be a subject matter expert in something that we've just kind of touched the surface on in EMS ever. So there are things out there that people can utilize, that they can go look at, but they have to go and find them. So I would really love to see that come together into a meaningful space, into a, hey, we've really sat down, we've talked with the people we need to talk to, and we've created this, and anybody can implement it. It's not going to be a protocol problem. It's just going to be things that you can use from your toolbox right now.
I know one of the things that we've done for neonatal resuscitation in the community birth setting is at the end, we do a whole training in the morning, and then in the afternoon it comes to the simulation part. And that is where you're able to take what birth may look like and what you're going to be walking in on many different scenarios. And you can see for people who attend this from EMS, their minds are like blown by this, because we're giving them the tub births. We're giving them the closet births. We're giving them the full Monty of, you've got a hemorrhage and a baby who's had a shoulder dystocia, mom's had a shoulder dystocia with a baby who's now not breathing, right? And they're working through all of this with the commotion in the background. And so they're learning from an environment of in the field, which is how we should be training, for sure. And it's really, that's one of the takeaways when they leave out of that. They're like, wow, this is great. And another thing we're doing is we're teaching, again, some of the home birth midwives are using a T-piece for resuscitation. It's much easier to resuscitate a baby with the T-piece because it's a softer inflation of the lungs. It works much better for CPAP, for PEEP, and so we're teaching that. And we're teaching it to EMS because we want them to be familiar that when they walk in on a scene, this might be what they're walking in on, and it's a piece of equipment they may have never had any access to or familiarity with. And especially freestanding birth centers, we're switching more over to that. So I can say, speaking from my point of view as a midwife, I've had to call EMS in for that, and I had to teach them on the fly how to use a T-piece because this is how the baby needed to be able to breathe with it. So
I'm just looking at time. I think I'd like to just touch on briefly a little bit about communication training too.
So important.
And how EMS providers can improve their communication with patients. It can be, as you've mentioned, it can be a high stress situation, working with the moms, and how can they train and prepare for that type of communication?
Yeah, I think naturally in our heads, we think we're communicating great with patients. But when you get into a birth and you have to think, how are we comparing this to other things we do, like a trauma or cardiac arrest? We're really, the patient normally, I mean, some traumas this is different, but the patient normally is not necessarily communicating with us. It's not necessarily something they're going to remember or something that we're really as focused on, because the immediate concern is you're bleeding out or you're already gone and we need to revive you, right? So in that instance, our communication is more based on talking to the family. And I think that comes up a lot in community births. I think if you were to watch an EMS crew by itself on a standalone do a home birth, there's probably a lot of talk between each other, and actually probably more talk between the medics and the dad than the medics and the mom. And what we really have to understand is she can't see. Like in the hospital, they'll ask, do you want a mirror, right? So you can see. She can't see. You need to walk her through this. I can see the baby's head. And that's important communication to have, because then she knows where she is, right? We think, oh, moms can feel it. They definitely know. It's not the case. So you need to be the one, oh, I can see the baby's head. Great, next push, make it nice and strong. Or, hey, here's the baby. I'm going to put him on your chest. Here's what's going on. Or you're bleeding a little bit too much. We need to give you X, Y, and Z, or do X, Y, and Z to help control that. It needs to be a refocus on mom and baby and less of a focus on team communication, because I think we do team communication pretty well. That's something that's not new in EMS. It's something that we have focused on in the last 5-10 years, bolstering team communication, debriefs, pre-briefs, sterile cockpit work, where you're just talking about the call you're going to. But we really have misstepped in the, oh, this patient is very much there with us, and not in the sense where you walk into somebody and they're sick and they're there with you. They're there with you through a very big life event and a very big medical event. So it's finding that balance of understanding, all right, how am I going to make sure I'm communicating with my team really efficiently, but include the mom in that as well, and include what we're doing. Are you doing delayed cord clamping? Great, why are you doing it? Maybe she's never heard of that. We have a pre-assumption that people have a lot more medical knowledge than they do. The research has basically shown us when you're talking about medical proficiency and medical literacy, it's being able to look at a chart and say that my child is 8, so they need this vaccine. That's a moderate-ish level of medical literacy. That's what we have to understand here, is we're going to get in there and we're going to immediately default to our medical knowledge and our medical jargon and all of that. It has to tone back down, and we have to bring it back to wherever the patient is, especially when you're looking at these deserts. They're very rural. The mom might not have ever had any care. She might not even know anything about what's going on with her body. And guess what? You're the educator now. So you get to have the birth and educate on what's going on, because she might not have any idea. And I think that's a big thing. And when we talked earlier about simulation and contextualizing it, that's a big part of it. You know, how are you communicating? Is the mom having a birth in a tub and she's got to stay in there? How are you communicating that to her? Because maybe that's not what she wants. Well, here's why, you know, why for you, why for your baby. And we've missed that because we haven't been training those births. So they don't know what to say. And I think that's a large part of the problem. Once we really step into that adjustment for what you should train for, then you can step into the adjustment of how to communicate it out.
I think I'm going to take this from, because you covered the EMS end of it really well, I'm going to take this from a midwife point of view for communication. And what we see with the literature, what it shows with the research, is that where a lot of the mistakes and things that happen is with lack of communication. And so when you as a midwife are calling EMS to the birth that you're having with your mama, there's almost this disconnect that can happen. And so one of the things that we've been working really hard with is myself as a midwife, from midwife to midwife, colleague to colleague, what the communication looks like when you call EMS right from the get-go. What does the 911 call look like? How does that sound? What is the information that you're delivering? Because what I'm getting back, the feedback that I'm getting back from midwives is, I'm dealing with an emergency right now. I don't have time to answer all the phone call, all the questions that are being asked from 911, right? So we start there when that's our training. And when EMS arrives on scene, the communication that occurs between midwife and EMS is super important. And you know, we've been trained in EMS. Oh, we need to know G's and 1s and P's and 2, like all these things, G's and P's and like all this stuff. And it's like, okay, actually, I think I'm going to give you my look at this is, I have a 36-year-old mother. She just delivered. We're having a postpartum hemorrhage. I have an IV in board. We've given this medication. We need to go now, right? That's the information to be given. So there's a lot of communication that needs to go on there. There are midwives in this country that have concerns about EMS providers that come in because of turf situations. I'm sure that definitely we have that concern. And so I say, hey, you know what? To me, it's an easy solve, because it's talking about where everyone's scope of practice is, and we're all going to work together. So what I do is when EMS is coming on a scene, I'm like, I'm inviting you in to help take care of what's going on here. Like, let's be a team together, right? And this is what we're going to do to work together to take the best care that we can of this mother or this baby or both of them. The other thing I want to look at too is provide a little more grace and when you're with as an EMT or a medic, when you're with your mother that's delivering, the language is going to be a little bit different that we're going to use because we're so used to coming on scene and like, this is our scene, we're taking charge, this is what we're doing, right? And when you're in a birth situation with a mother, especially who's been very well informed, that's not her goal and that's not what she's expecting. So when you're walking in, it's being soft, it's being present, it's taking that moment to pause, it's getting down on her level, it's making eye contact. May I touch you? It looks like your baby's about to be born. Look at me. Make the eye contact. Oh, like you said, I see your baby's head. You're doing great. I know this feels really scary right now in this moment, but we're going to be there and do it together, right? So it's different language that you're going to use. That we want her to feel seen and heard and safe. That's so important. And then also including the partner if they want to be, right? Mm-hmm. Hey, do you see your baby's coming? Look, like here's your child, your baby's coming. Do you want to touch your baby's head? Right? I know that sounds like an odd thing, but some people want to do that, and it helps bring everybody around together. So it's the communication, it's getting consent. Another thing is in saying, I'm going to give you this medication. It's, hey, I'm noticing this is what's going on right now, and I'm a little concerned with the amount that you're bleeding. Is it okay with you if we go ahead and do X, Y, Z? Explain everything before you do it. Explain it. That's super important. So those are some of my communication tips that I see from my end as a midwife that I'd like to bring forward on ways that we can absolutely approach it from a different mindset.
I've learned so much from both of you in our short time today. I know we could go on for hours and hours on this. I do want to leave some time for Q&A, and I thank you for those that have submitted some questions in advance. Please remember you can also submit your questions in chat. I just have one question before we go to the Q&A of how can attendees stay engaged and continue learning after today's webinar?
Yeah, that's a good one. So like I kind of mentioned, we have a lot of bits and pieces, and I hate to say go out and find them. So I think if you ever wanted to contact Melissa or I, we're very open to add us on LinkedIn, add us on whatever you want to do to contact us wise. We're happy to give you as many resources as we think would benefit you and your agency. The other thing is, go look at Step Up Together. Go educate yourself on maternity care deserts. Go talk to your local midwife. We talk about communication, and I wanted to come back to that because I did look at it from an EMS perspective, and Melissa kind of gave you the midwife perspective. But it is a collaboration. How much easier is it going to be if you walk into a home or a birth center and you already know that person? I can walk in, I know what Melissa is going to have already done. I know what she's going to tell me she needs, and I know that I can trust her in that follow-up. You can do that, go out, ask your local midwife, hey, can we have some people come shadow you? Can you come teach us some stuff? Your doulas are very involved, and they're very good at the communication piece. They are excellent when it comes to talking to mothers on that front. So if maybe you get too wrapped up in something, or the midwife there gets too wrapped up in something, you have that third party and you know what they're going to do. So I think really just stepping out, get out of the mentality of this is not going to happen enough that I need to really train on it, and then step back out into your community and say, how can we support you? We know it's going to happen one day. So how can we collaborate the best way we can to make sure that everybody is moved along the journey as safe and efficiently as possible, but also in a manner that is really respectful of the actual thing that's happening, which is a brand new baby's coming into this world. And it's such a cool thing, right? Like if you've ever gone to a birth, it's such a cool thing, especially when it happens flawlessly, in the event that it happens flawlessly. But I really do think that that is the missing piece, like Melissa said. It has to be a continuum. We talk about the continuum of care all the time when it comes to arrest and trauma. It's the same with births. You just have to do a little more legwork to go out and get your resources, but if you focus on that community piece, it's going to be a lot easier for you, and then you can pull from those experts to come and do those trainings that we talked about.
That's great advice.
Yeah, absolutely. And I know when I talk to my midwife colleagues or when I go out and I speak about this nationally, I say to them, go knock on the door.
Yeah.
Knock on their door. Bring them a plate of chocolate chip cookies, fresh out of the oven preferably, so they're smelling. I'm like, and you know what? They might let you in a little bit, but then once they smell the cookies, they're going to let you in. Yeah. So go in, and chat this up, collaborate this, work together. It would be amazing, and my heart would be like overjoyed if we could actually pull in EMS to attend out of hospital births alongside us. Like, that would be incredible. To me, that would just be like the whipped cream and the sprinkles on top of the sundae, right? So until that actually happens, right, collaborate together, do the trainings together, become one on the same team, learn what each other has at their disposal. When I go out to a home birth or anything that's in a birth center, you would be surprised the amount of equipment and medication and all the things that I have that come with me on these, right? There are things that you might not have on your rig. And then as a midwife, they may not understand what's on your rig. So learn together. The other thing is, when you go into a birth center, learn how to negotiate your stretcher in and out of a birth center. These are things that can be, like, it's a minor little thing, but you're doing it together. So the collaboration, I think, is a key component to this, and the education.
Thank you.
Thank you.
I'm going to turn to some of the questions that have come in. And you mentioned EMS rigs. We did get a question that came in on that, asking, is the equipment that's on most EMS rigs, is it adequate for maternal emergencies, or what's missing?
Want me to go first? What I think is missing? So it's a great question, and on most ambulances you have a standard OB kit, right? You're going to have some clamps in there for the umbilical cord. You might have scissors or a scalpel. There's going to be like one underpad, one chuck pad for absorbing blood, and maybe a bulb syringe, some gauze pads, and some alcohol swabs. This can be bolstered so much. Like Melissa said, if you have NRP training, have the T piece. Are you bringing in whatever baby bag that you use if the baby needs to be resuscitated? So just remembering that the maternal kit and the infant resuscitation kit are not separate. They need to come in together, sort of deal. The other thing that I would love to see ambulances carry is a standalone correct thermometer for infants. You don't have to do a rectal temperature. You can do under the armpit. It will be okay. Of course, rectal is going to give you better, but if mom might say no, that's her kid, right? So just understanding those pieces. I'd also love to see something to weigh the baby with. It's kind of like a cardiac arrest in that once you get ROSC, you've got some time to do some things, even if you're going to transport for the most part. So what are you filling that space with to help that infant? Do you have those warm blankets? Do you have, in my mind, I also would love to see something for mom, something postpartum for mom, especially if you're thinking roadside births. You're not putting pressure on anything here, right? You need a standalone blood management product in there, whether that be postpartum briefs or even just adult diapers are great, actually. So just bolstering some things into that kit would be wonderful. Tylenol for mom, we'd love to see that, because you're going to be sore. Something to manage that isn't necessarily a harder pain med, because you don't want to give that to a mom right after birth. So that kit just needs to be bolstered. There needs to be more of what's in there. Like one chuck pad isn't enough. I think we can all agree with that if you've ever been to a birth. And just some little educational materials I would love to see, because you don't see it as much. So what if there is a breech birth? Well, what is that kind of checklist? What is the postpartum kind of algorithm that you're going to work down, so that providers can go in knowing, I don't have to memorize all of this. I do have some resources there to look at and to say, okay, this is definitely a hemorrhage. That card, just flip to that card. Okay, here we go. And that's okay. Honestly, as a mom who's had, I think as all moms here, we can say, I would rather my provider be looking at something to double check themselves than they just kind of fly by the cuff. I feel this way about anybody in healthcare. If I go to the doctor and he says, I'm not really sure, let me go look it up and look into some things. Fantastic. You can't memorize all of it. I think that's something in healthcare that we as patients need to realize. They can't know it and memorize it all. So having some of those resources there to refer to, I think would be incredibly beneficial.
Anything else you can think of?
I would highly recommend that everyone go into their rigs and make sure they have the correct size neonatal BVM.
That is
You'd
good
be
too.
surprised that the face piece is not for an infant. It might be for a pediatric, right? That's not going to fit a newborn. So go in there and do that. To me, that is crucial. So I'm going to end on that.
Okay,
Oh, I have one more
sure.
because we
might add in one
talked
more
about this. Correct transport items. You know, how are you transporting that infant skin to skin? Because car seats are really not meant for the ambulance. Maybe mom is too tired or hemorrhaging to hold. So how is dad going to come in and hold the baby? You know, really thinking about that aspect, because that is really also a missed part. We're talking about it more and more. Transport on the trucks for newborns. We've got stuff for peds, but a pediatric patient is not the same as a newborn patient. So look into some of those other things that you could use that really help foster that skin to skin on the mom, and are safe. So you want to look at things that have actually passed those crash tests in the truck. There are a few things out there, so look into them, make sure that your trucks are as equipped for that as possible.
Okay. I know we're not going to have time to answer all of the questions, so if you've submitted a question that we are not going to have time to cover today, we will do our best to answer those in the chat or send them after the webinar. There is one more I'd like to touch on briefly if we have time. What are some future topics or innovations that EMS professionals should be aware of, or things to watch for in maternal care? What's to come?
I know I would like to focus on our role as EMS in the maternal mental health space. So when we look at the morbidity and mortality rates for new moms, it's postpartum period, and it's for the first year after they've given birth, and mental health is the #1 cause. It's overdoses and it's suicides. So I would like us to play more of a role in that. That might be an area that we can really fill a gap, for sure.
Yeah, I selfishly, because I'm deep in that space as well. I agree with Melissa. I think the understanding of PMADS is really important. So that's perinatal mood and anxiety disorders. We often are taught postpartum depression and that's it. There's so much more to it that you might have to manage, and it is wildly important. And I think coming into the future, what we're really going to start seeing is, instead of those chunks, birth, neonatal resuscitation, now you're somewhere else postpartum and we'll have to manage that in some other way, and you're somewhere being pregnant and we're going to have to manage that in another way. I think what we're going to see is an understanding of training across the continuum, and I would like to see it at the moment that you know you're pregnant all the way up to, like Melissa said, 1 year after you've had your child. That is, it's not the full window, but it's a big enough window, I think, to really understand the progression of what you might have to respond to, because it's so much more than just a standalone, here's birth, now here's the baby, and here's this, and here's that. You have to understand the whole process and the health continuum throughout. And like Melissa said earlier, some of that is social determinants of health. Are they even able to get anywhere to get care? Some of that is the actual birthing process, resuscitation if you gotta, and then PMADS afterward. So I think what's going to start happening is we're going to see more almost community paramedicine style work in the maternal space, and that's going to be kind of the driver to move forward.
I think one other area I'd like to hit home on for
Please.
as well, because you and I are speaking, we always speak the same language with this, is also the sepsis that can occur in the postpartum period. We're losing moms to that too. And so being knowledgeable of what sepsis looks like in a postpartum woman is super important. And calling that code sepsis on the way into the hospital, so we're getting the treatment much faster. And if you're in your protocols and able to, start the antibiotics and give the fluids on the rig before she's even getting in. So that's another area too that we can absolutely make a quick difference on.
Thank you again for joining us today. We hope this was valuable information for you to share with your teams as well. And we look forward to talking with you in the future.